Okay, colleagues, I think we're ready to roll again. And the next item up is the Integrated Finance and Performance Report. And this is David's chance to do some choreography. He's always wanted to do Strictly, I believe. So over to you, David.
Thank you, Boyd. This is as close as I'll ever get to that, I can assure you. Thank you. Good morning, everyone. And you have in your papers today the March update with our IPQR. Of course, you're reminded that the details of the IPQR go through a number of subcommittees of the board, as well as the integration boards that are relevant for Highland. The bit of context before I give a bit of a summary, then open it to questions. Last week we had to submit our update to RMP4. That will be the last update we do of that particular plan. The specific target around that recovery plan was that each board should go back to pre-pandemic levels with regard to outpatients and TTG by September of this year. So we have submitted a plan that does that, and we will continue to work with government in terms of their support around that. We will be able to give you bring an update at the next board meeting with our progress against that plan, and obviously we have the infrastructure within the organisation to manage and reference our performance to that. That's going to be extremely challenging because I'm sure the content of the report is very obviously pointing to a very hot and difficult system at the moment. That is almost entirely across all of the metrics that you would see in terms of ED performance. Our outpatients and TTG challenge that faces us is there, and our delayed discharges. So it points to pressures across the system, both in acute health as well as health and social care. And that makes it a very challenging environment in which to recover. The charts that Tim shared with us earlier certainly point to signs of optimism, cautious optimism, I think was the term that Tim used. And we recognise that recovery will be essential for us to be able to really step up in terms of our waiting times recovery that is desired and required. I think just one positive note in amongst all of that pressure, I'll bring to your attention the cancer performance. In previous sessions of the board, we've talked about the review around our cancer services, and that continues to show signs of progress. It is extremely challenging for the team, but yet they have persisted in the progress that they have made, and I think that's great recognition to the team that are working in this area, but also a lot of the other support services round about that, because it is really a cross-functional team that supports patients through these pathways and even relies upon support from other boards. And so some of that is challenging. It's not been straightforward, but nonetheless, progress continues to be made. In terms of the format of the IPQR, you'll see that it is continues to evolve, and thank you for your feedback. But thanks to Lorraine and her team who do all the hard work on this and produce the information in a way that's as easy to digest as possible. There are always additional metrics that we don't show, additional information. That's just the nature of data itself. But we are absolutely with open ears to hear what would be of more help to you and to be able to better understand the metrics that are there. You'll notice finally that there is a section at the end related to Argyll and Bute. That was a request that was made, and we'll seek to evolve that over time as well, but hopefully the board finds that helpful. So happy to open it up for questions now, and as per usual, I have many of our colleagues on the phone that will be happy to answer questions and support the answers in a more detailed way than perhaps what I could give. Alistair.
Yeah, thank you. It's probably not so much a question, it's just a follow on. I'm really pleased, David, with the way, to the other execs, the way this report is evolving. It's allowing us to scrutinise and evaluate quite easily, and the improvements around the cancer-related matters are obviously totally welcomed. And if you could convey thanks to the staff, I think that would be very much appreciated on this. I was just wondering if, this is quite an easy document to read now. It's laid out so well. I was just wondering if you could perhaps just explain a little bit how this information is used and cascaded throughout the organisation, so that everybody gets a good understanding of the direction of travel and the excellent performance results that are embedded in this report. Thank you.
Thanks, Alistair. I might be bring Lorraine in if you wanted to talk, Lorraine, just a little about how the cascade works and how that information is shared and the various groups that are looking at that, if that's possible.
Yeah, thanks, Alistair. That's a really good question. What we're working on underneath, as David described, is some more granular detail for each of the, sectors or programme boards, as we've got them called. So been working with Louise and Anne on what social care community will look like in terms of a overview dashboard, and the same with scheduled care and mental health and other areas. So we're working on, how that's used on a daily basis and how we can get to that single point of truth throughout the organisation for the data, and then how we base our actions and action plans based on that. So I guess it's done very succinctly with rigour throughout the organisation with all interested parties for the programme boards, and we develop action plans based on that. So you're seeing the kind of high level, but we obviously work with the chief officers and the teams to develop that granularity below. And I'm happy to go through some of that dashboards with you if you would find them of interest.
Thanks, Lorraine. And obviously, Alistair, you'll understand that as you go down into those details, then the one metric perhaps that you see in this summary document actually spawns 5 or 6 different detailed analysis that actually gives you the leading indicators towards what you're seeing. But it's an ongoing challenge to make sure it's visible. Certainly it's visible to the subcommittees of the board. It's going through PRB in its various formats, which is our management board, which reviews performance, and into the services themselves. But it's important that we try to get it out as far as possible, but also to the right level of detail where that's required. Susan Ringley.
Thank you, David, and agree with others. Really appreciate this format, the variety in the presentation as well. Visually, the numbers. I think it's really giving us a good picture. Equally, good to hear about the cancer treatment times. When I was at the Lawn in the Isles Hospital the other week, the staff there said they were concerned in the Macmillan Centre they've got there. They were concerned about a late presentation of people coming in much later for treatment. Now, this wasn't delay from our side, but people had either been reluctant to come forward, they didn't want to take up services when they thought others were needing them, or they were wary about coming into hospital, fearing, that they might be exposed to COVID or whatever. And all of that makes it even more important that we don't add to that delay if there is a late presentation. And firstly, I wondered if that was something you'd seen across the piece. But then I've got a particular question about the chart on page 191. I don't quite understand the y-axis there. I can see month by month with numbers in a bar chart, but I don't know what those. Are they telling me the number of people who are waiting that period of time? How does that relate to the standard? Am I missing something there? And
that's the chart 191 is related to the cancer performance. Is that right, Susan? I'm just checking I'm looking at the right report. Oh, you're on mute. You're on mute, Susan. You're on mute. Yeah.
Sorry, my mistake. It shows bar charts on months from April through to February with numbers of people.
Yeah, Lorraine, do you want to answer that question, and then
Yes,
I'll come
numbers of people treated within that month, Susan.
So how does that relate to the
Patient numbers? So
how does that relate to the performance target of how many were treated within time?
So the performance targets based on the, I guess, the number of patients going through and how many people reach that within 31 or 62 days. So that's how the calculation's made nationally. But I agree, I think that one needs a little bit of work in terms of the percentages going through.
So the reality is it's just been able to look at both of those charts together. One is the percentage performance and the other shows the actual flow through the services. And it just gives you that additional context. The first part of your question, if I can come to Boyd to talk about the late presentation element, if I can, thanks.
Yeah, thanks. So you mentioned concerns that staff in one hospital gave. It's a national consideration, has been a phenomenon through COVID that people were presenting late or presenting through different routes. And so there's national data gathering around this. One would expect that if we return to, if you like, a normal way of working or closer to normal, we might see some of that reversed. Lung cancer, for instance, there was a great concern about that, but it turned out the presentation was through different routes, and there was still actually a much higher presentation of lung cancer than anticipated. And weirdly, I picked up recently that the data is starting to show that more people have presented with ovarian than had would have been expected. So actually, I think although staff and any individual will give you a concern and an observation about small thing, and it may be of pertinence and relevance, the key is to look at what the data across the nation is telling us, and it's a developing picture. And some of the worries that we have had nationally in Scotland have not entirely borne out, but instead things have happened differently. But there will be some people who didn't present as early with their cancer as they might have done. Some of the recovery plan approach will need to take that in mind about what do we do about catch up, because maybe there'll be a lot of people who suddenly come with cancer and at a more advanced state. So this is all part of the cancer national strategy thinking at the moment, and that then bears down into how boards must approach it too.
Thanks for your question, Susan. If I can come to Graham.
Thanks, David. I echo other comments about how good it is to be able to understand the various various pieces of information that are presented, but also to understand that the scale of the challenge it is laid very bare, because it's being presented in such a clear way. So you're not quite making a rod for your own back, but you know what I mean when I say that. But I think it's a great step forward. My question relates, David, almost as much to your opening comment about the remobilisation plans, and part of that was about redesign. And I'm just struggling a bit to pick up where redesign is being really tackled, both here, and I'm wondering just about what the national kind of expectation on service redesign is work being done on this, and or is it too early? You know, because I appreciate a lot of that. We'll be trying to look and understand and change the way things are done. But I'm just interested to hear what's happening about the redesign element of remobilisation. Thanks.
Thanks, Graham. I'll bring Catherine in just a second. But just to clarify in my comments, the target government have set it is to reach those levels of activity. They're not suggesting we do that in the same way that we did it prior to that. So there is a very clear expectation that we would do things differently. And indeed, the circumstances in which we now operate is with COVID as opposed to without COVID. And again, that creates challenges in itself. But very much that redesign is at a service level as opposed to necessarily an organisational level. But Catherine, maybe you could add some more information to that for us.
Thanks, David. So you'll know, Graham, that we've talked previously around the work streams that we've got around outpatients and also around getting into our theatres. So it's that development work that we are looking now to absolutely embed across every service. So things such as the virtual appointments to ensure that they continue and that there's easier access for people. Looking at the volume of patients that are waiting return outpatient appointments and recognising that actually these people would be better served to be able to come in when their conditions are flaring, particularly long-term conditions. So it's those types of things that we've been working for a very long time on, as well as, you know, you'll have heard clinical dialogue and these other types of initiatives that we've developed. But because of the pandemic, we've not managed to embed them in the intricate detail that we'd like to across all services. So it's that work that we are going to be continuing to work with our services on. In terms of our remobilisation, we will obviously, because of the size of the waiting list, we will need some additionality as well. You know, this year it's going to be a combination of additionality and redesign in service with a view to get into sustainable services going forward.
I'll bring in Pam just in a second. Maybe she can give some context about the national picture, which might be helpful. But maybe just to pick up one comment you made around the data and transparency. I think we're going to be entering in a really challenging period over the next couple of years as we recover, because as we recover, it will not be as fast as what our population would like, nor our clinicians would like, nor any of us would like. And there will be levels of frustration from individuals who are waiting treatment, and that's completely understandable. What we need to do, and what we want to do, is be as transparent with all of our folks who are interested, whether that be the patient or politicians or communities, so that planning or expectation can be made. But that is a very difficult thing to be able to be that predictable at this point in time. But we are going to try to work towards how we can be more predictable. But it's going to be a difficult period. And the last thing we want to do is be covert about it. So we want for sure the board to see exactly where we are and what our progress is, warts and all, and be assured that where there are bumps in the road, which we will come across, then we'll be working hard to try and clear them and accelerate our recovery as fast as possible. But maybe Pam, you could mention about the national picture, please.
Yeah, I think, Graham, you've articulated the kind of your observations very well made, that it is good that we can see exactly where we're at, albeit that's not always a comfortable thing to read. I think nationally that's the case. That through the pandemic, what the position we're in now and where we need to get back to is extremely challenging and extremely daunting in terms of how do you redesign to get to that point. Nationally, there are 4 care programmes, and that is the framework in which planning is taking place. And there's a planned care, which is around the aspects that Catherine was talking about in terms of elective. There is the unscheduled, which is all the right from community through to our 4-hour target pathways. There's the preventative and proactive care, which is going to really be focused around the future of health and social care, if you like, in that kind of community setting. What are the aspects there, such as the National Care Service? And I sit on that as a chief exec as part of my national role. And then there's the population health one, which it does what it says in the tin, looks at all the preventative stuff and very much around the public health messaging and communities and community planning. And so I think nationally they are trying to draw together some coherence in that and are pulling together a delivery plan for us. They are also, the digital team are looking at how you could optimise a digital front door for health and social care. What would that look like, and how would you expand on the learning to date, as others have said, and what else could that be? And that's a bit of a philosophical change for practice as well. So to what level would you take that, and how acceptable is that to the public? And there is quite a strong emphasis coming forward in terms of what's our next iteration of community got to look like in order to be able to optimise prevention, keep people well in their communities, and have the right set of services. That means it's not that different. That means people aren't going to hospital. I think the tricky bit for everybody is that obviously we've got a here and now challenge in people that urgently need intervention, and we're not managing to meet those obligations in the way we would wish to, versus we need to redesign. And I think that's probably the capacity component that we are challenged with at times, but the reason we've put in the kind of programme approach to try and systematically work through some of that. The other bit that I think rings well with what's been discussed and developed nationally is the refreshed approach that we took to the Joint Monitoring Committee for the Highland Health and Social Care Partnership, of working with communities. Tara led on that with others, how we work differently with communities and try and flip the lens a little bit in terms of how we might build up a future, more sustainable, long-term, locality-focused model. So we are entering into that territory locally, and I'm quite satisfied that the discussions happening nationally and the frameworks they're trying to bring together will match with that, albeit I think we are being really ambitious about the level of reform we might be able to do. And that question nationally is, how do you balance the current situation with the reform requirement? And I think that'll be the tension going forward.
Thanks, Pam.
Just one quick final response to that. At our local GP surgery, they were talking about how much more efficient they've become in terms of throughput. They said, but the annoying thing is no one sees it, because they've actually become a lot more efficient at also making patients move through quickly. So there aren't the there aren't the obvious signs of a place being busy. So one of the frustrations of improvement. Thank you.
Yeah, I think there's an issue with data there as well, because the GP data isn't part of the data sets that are shared, so people don't see it, and that's probably a bit tricky too. And we're back to user experience. You know, that we've still got a mindset as a society that we need to be seen.
Yeah, and before we move on, we had a review of our pharmacy services and community pharmacy, and the amount of work that community pharmacies are doing in support in that early intervention stage with individuals, and had some personal experience of that recently, and really fantastic service by many of our community pharmacies. And what they're able to do is far greater than what they were doing previously and allowed to do previously, but they're really stepping up in that as well. So that's some of the types of redesign that's going on. But thanks for the question. Bert, if I can come to you.
Thank you, David. Sorry, I think there's maybe a problem with my mic. You hearing me okay?
Yeah, we can hear you.
Yes, sorry, it's been problematic. Yeah, like others, I appreciate the format of how the data is being presented, but I just need some help in trying to understand a little bit about some of that data, and I'm thinking particularly about serious adverse events. So the information that's presented shows figures in a box, which takes us to September. Underneath that, there's year-to-date figures, and on the left-hand side, there is a graph. Now, maybe it's just me, but I would appreciate some help in understanding what all of that different figures are telling us. So if you look at the serious adverse event reviews in the box, we're looking at data up until September. As I said earlier, underneath that, the year to date, and then on the left-hand side, a graph which actually takes us up until February 22. So maybe if somebody could clarify that for me, and then underneath that, the complaints. We've got data which takes us up to August of last year, showing us 22%, which actually is about 8 months ago or 7 months ago. But there isn't that additional information that was provided, for example, in the serious adverse events. So I would just appreciate some explanation for that. Thank you.
Thanks. Bert, these are good observations. I think, firstly, in general, the timing of data can vary in terms of at what point these are formally reported. I do recognise what you're saying. We did have some technical challenges around the report this particular month, to which and it may be that some of this data has been corrupted as it got into its final version. But in general, in terms of how the data reports together, I wonder, Boyd, if you want to mention that. But what we can do is happy to issue an update to this section as we have that, if that data is restored, and we can certainly do that after the board meeting today, so apologies. But Boyd, did you want to come in just in terms of explaining how it fits together?
Sorry, the full answer is probably very long, but the short answer, the September is because the significant adverse event reviews have a 6-month time target, and so you can't measure the target until six months. You know, if it's been 5 months, then it hasn't hit the target, so it's not reportable yet, and that's where the September bit fits in. I think I agree with you. I've asked for some changes to be made in how SAERs get reported, because actually it's a slow-moving train, because things take a while. The numbers that come in as new are very small, and so it's hard to see trends and patterns in that. But we're working on what might be a meaningful presentation, because although I appreciate there have been some data issues this time, but also I think that section hasn't been, it maybe hasn't helped people to quickly understand what are the issues, what are the assurances, and what needs to happen next. And I don't think that we get there with what's there yet, but we're working on that. The other thing to note is that adverse event is another term, which is basically the number of DATIX reports, and so that can cause confusion as well. And there are different numbers for that. And the final thing is with again with complaints, there are we're looking for ways. I've asked for better graphic representation of the overall complaint situation, and I've now got some drafts in front of me. So I would expect, as described in the general part of this section, that the evolution will continue, and the aim is to get visual representation of data that will allow the inquiry that is needed at board level, but also will carry meaning for others within the body of the organisation as well.
Thanks, Boyd.
Thank you very much. Can I just come back for a second?
Yes, of course.
Yeah, so I appreciate that explanation, and it strikes me that there is perhaps still a little bit of work to be done there in terms of how the information is assembled and presented. My final query, I suppose, in relation to the IPQR is in relation to, I guess, the staff things, and I was looking for some information there in relation to statutory and mandatory training. Now, I know that goes through staff governance, but it's been such an area of concern over a period of time that perhaps naively I'm thinking that should really be featuring in that IPQR, and I just wonder if I'm out of kilter in that thinking, or if this is a work in progress. Thank you.
Thanks for your question, Bert. We're happy to include that. Fiona, did you want to add any comment to that?
Yeah, just to say really that we've been looking at all of our indicators for both the Staff Governance Committee and for the IPQR people section. So it's definitely an area we're looking at. We want to make sure, obviously, we're aligned to the 5 staff governance standards, which include our performance around health and safety, and well-being, as well as around some of the more traditional metrics. So following the staff governance development session that we had at the beginning of this month, where we talked about what some of the outcomes we would like to be able to evidence, we're now going away to look at what information we could provide and in what sort of cycle. So it is definitely something that we wouldn't see it featuring in every report, but it's certainly something that from a board perspective, it is one that we would want to present and track progress on.
Thanks, Bert, and I appreciate that. So it sounds like we will have an update for the next time around. So thanks for raising those items. Finally, if I can come to Alex.
Thanks, David. Yeah, a couple of observations and a couple of questions. Like everybody else, I'm delighted that the cancer numbers are looking good and continuing to go up, and that's something that is very, very pleasing indeed. One of the things I do with this particular document is I don't look necessarily at the number this month. I'll look at the trends. I'll look to see which way the graphs are going, up, down, sideways. The observation bit is when you look at TTG performance, it's relatively static, and that's probably because the next slide down shows that orthopedics are skewing this thing massively. Now, is there a possibility, Lorraine, of seeing that without the orthopedics in it? So we could actually start to see if everything else is getting better, it's just orthopedics that's slowing it up, and vice versa. So at least we can start to see an up and down there, if possible. For Catherine, in the 4-hour ED access targets, what does ED conversion rate mean, and what does 21.8% feel like? Is that good, bad? It doesn't feel good, but I don't understand what it is and what it's telling me. And for Heidi, on the falls, the slip, strips and inpatient falls, that trend is up, and it's been up for about a year. Do we understand why? Is that the kind of thing that we look at? Again, I'm talking about a trend, not a month by month basis. Is that something that we can do in terms of improving buildings and etc.? Because I don't think that can be purely COVID related, whereas some of the others can. Thanks.
Thanks, Alex, for your question. I'll come to Catherine if you can answer the first part of that around the performance rates.
Yeah, thanks for the question, Alex. There isn't obviously an NHS Scotland comparator, as you can see in the report. So that basically tells us that 1/5 of our presentations at the emergency department is currently being converted into an admission. So that's something that that is a KPI for us within our unscheduled care improvement work. To look at, how can we reduce that? What can we do perhaps to look at people that are frequent attenders at the emergency department? How well are our sort of anticipatory care plans working? are there patients with specific needs that we need to wrap around? So that's the reason for sharing that particular metric, Alex. And I'd love to know what the national one is, but maybe Lorraine would be able to uncover that for us.
I don't think she'll be able to pluck it out there for the moment, but I think that's a useful benchmark to have, and hopefully the benchmarks are quite helpful as we go through the reports. Heidi, can I come to you with regard to the falls?
Sorry, took me a moment to get my mic off there. Thanks, Alex. Yes, so happy to take you through falls. So after July 2021, what we've seen are 10 points above the mean. So that indicates to us that, like you say, we have a trend, and that mean is going to go up very shortly. Before that, what we saw was really very significant random variation of the data, and no trend at all. So so you're right, we're seeing a trend just above the mean. We're seeing even more variation though locally, and that's where we're focusing our attention at the moment. So we have areas that are sustaining good levels of falls, and are not seeing a rise in falls, but we are seeing a number of areas where we are seeing an increase in falls. What we've used is the Pareto tool, and that's the 80-20 tool where we look at the top areas, if you like, that are causing, there's a small number of areas that are seeing a higher rate of falls. And what we're doing is we're focusing our attention on those areas. What we've done to address it so far then, we have reinvigorated our falls prevention group. We have our associate AHP director leading on that group. They are specifically looking at the data and directing the improvement work. We have employed additional quality improvement staff to specifically support us with falls, and that work is just beginning to get a grip. We're going to put more people into the system. In fact, we only had that conversation yesterday, and I've agreed that we'll put additional people into the system to support that improvement work, because I think we need it at the moment. We're also looking at the recruitment of a consultant, either AHP or nurse, to lead on falls prevention for us, and to bring some expertise into the system that we can use. So, and of course, the other thing, of course, is we've also got the national falls prevention programme that's now live, and that's really supportive, because that's where we get all of the learning and the new ideas from across Scotland, and of course across the world too. So we're cited and actioning it. It'll probably take us a moment or two to see that downward trend, but we've got things in place that should impact on the reduction in falls.
Thanks, Heidi. I think that concludes the questions, Boyd. And yes, sorry, I do apologise, Chair, I've gone over the time by 5 minutes again, but hopefully that's been helpful today. Thank you.
Thank you very much, David, and thank you, Lorraine, too, for all the work you do on this document. One just point from me, strikes me that in the narration parts of these pages, quite a lot of reference to staffing issues. And there's a workforce strategy being produced by the Scottish Government recently in conjunction with COSLA. I think it would be timely for us to have a discussion, maybe at a development session, Pam, about that document, and also some kind of overview of where we are in terms of our staffing complement. Where are the gaps that prevent us making progress in certain areas? That would be quite helpful. Okay, we're asked to take substantial assurance from the report, and I think we are, in all indications are that we're taking substantial assurance. Yeah, okay, thanks. Can we move on then to item 9, the finance assurance report? And David.
Thanks, Chair. Hopefully I'll be able to make up some of David's time in this one. Like the performance report, this is all the financial position is also scrutinised at Finance Committee, so it's a relatively high level summary that's presented today. The position shown is the financial position at month 11. Members will recall at the last board meeting, we highlighted the fact that government had announced that boards would be provided with sufficient funds to allow break even during the COVID year that we're facing this year, and that's now reflected within the financial report that's before you. We've tried to change the finance report slightly in terms to show the if you like the operational overspends that are there net of COVID, if you like, and excluding if you like savings under delivery. What the report is telling you right now is that the year-to-date overspend that we're seeing is £3.5 million, and we expect that to be broadly the same at the end of the year, with some slight movements between the operational units. That split is likely to be about £4 million of an overspend, with an acute offset by some relatively small underspends in other areas. As well as the money that we've been given to deliver break even in the current year, we've also just recently been awarded or notified, sorry, of some more additional COVID monies that are being passed through to integration authorities in the current year, which will be a first call on any COVID expenditure next year. The expectation is that IGPs will carry these amounts in their IGB reserves into next year, and the amounts that we are going to receive in the current year it comes to a staggering £48.5 million. Allocation letters for that are due in March, and that's split with £11.9 million of that will come into Argyll Bute, 25 to the Health and Social Care Partnership in Highland, and £11 million in respect of other board services. Members will know that obviously that Argyll Bute IGP are able to carry that within their reserves, but we don't have that ability within the Highland Partnership, and we're in conversations with government to allow us to, if you like, facilitate that return of the resource to government, so they could almost act as our IGB reserve going into next year. So they'll hold the money for us through the year end, and then give it to us back again next year, and allow us to operate it in the same way as an IGB reserve, and that'll be reflected in the month 12 numbers when they come out in April. So a position that we're still reporting as a break even, and that includes £10.9 million, I think it is, of undelivered savings, unachieved savings. As you know, we had a savings target of £32.9 million at the start of the year, and we're expecting that to be covered by either government funding or in the main non-recurring savings that we've delivered in the current year, which of course will impact the carry forward going into next year and present a higher gap going into next year. And that'll be reported at the next board meeting going forward. In terms of capital spend, the report on page 20 of the papers shows the major schemes that we're spending money on. The Skye and Bannock Trustee hospitals and the National Treatment Centre, which we're talking about next, are the three main schemes that we're spending about £30 million on in total. But as well as that, there's a whole range of additional resources and additional projects, that are being spent on. And a huge challenge to spend by the end of the last year, but we're on course to do it, as we all seem to be with capital. The spend always seems to happen at the end of the financial year. So I think, as I said, I'll be brief and happy to answer any questions. I guess the main issue is we are breaking even, and we've got some additional monies that the government are hopefully helping us all with for North Highland, and our capital spend is significant, but likely to be on track.
Thank you very much, Dave. Questions or comments for Dave? Sarah?
Thanks. Maybe slightly left field. It's about one of the items that you have highlighted in section 4 around financial risks. The Argyll and Bute SLA with Greater Glasgow and Clyde. So obviously after much work on both sides, that was resolved for the period that we're in currently, but very aware that the new financial year is breathing down our neck. And although we had found a solution for this year, that is an open question as to how we go forward. And I can see your update says it's under review as they're developing a revised model. It would be interesting to know if we have an update on that.
I personally don't have any updates on that, Sarah, but George Morrison, who I think isn't here, may have something.
Yeah, I'm here. I don't think it's a revised model just for Argyll and Bute, Sarah. I think it's discussions that are taking place on a national basis, because all of the SLAs between boards were based on historic activity levels, but obviously that was significantly disrupted by COVID, and it created it skewed all the activity data. So the basis on which all the SLAs have been established across the country has been distorted, and that's given rise to stimulated a conversation to review the basis of SLA calculations. I think it's been taken forward by some national finance group, and they're having discussions around that, but I don't think it's unique to Glasgow and Argyll and Bute.
Thanks. Thanks, George. Yeah, I guess I would just be interested. I mean, I'm sure we'll be updated as that unfolds, but I suppose just given where we were previously with the SLA, slightly apprehensive about going into the new financial year with that unknown risk, I guess.
This financial year, we based the SLA on the previous financial year and didn't take account of the activity fluctuations. Not entirely sure how we're geared up for setting the SLA value for 22-23, but we'll have a discussion internally in Argyll and Bute, and I'll let you know how that's gearing up.
Thanks.
Thanks, George. Alex, and then Jerry.
Thanks, Jeff. Yeah, thanks, Dave. The savings always amazes me. I mean, the fact that we got 20 odd million pounds of savings in during COVID is just, it's remarkable, and paying tribute to the staff that have achieved that. But my usual concern at this time of year is that capital numbers. The almost 8.8 million for NTC that have yet to be spent. Can we carry any of that across? Is that the totality for the spend for National Treatment Centre, or is there more money for next year and the 8.8 has to be spent in this year, or can it be deferred into next year? And it's similarly for radiotherapy. You've got almost 3.5 million sitting on, to be spent on radiotherapy. 96 to date, 96,000 to date. So is that some big bits of kit that have come in, or what's the reason for the the spend imbalance at this time? I think
sorry, Alan will probably come in behind me, but we are definitely on track to spend in line with the estimates. They're always changing every day, Jerry, and we're having the team laid from one project to another, just to make the actual balance. But Alan will come in and probably give a better explanation than I.
Yeah, sorry, in regards to the NTC, Alex, that's the spend profile, and we're matching the spend profile. So we'll do an assessment mid-March, which will balance that 8.9 million out. So that's this year financial spend. The radiology is we're just receipting a delivery, some equipment again there, and the other bits and pieces. It's more, you'll see one endoscopy, scopes and that too. So it's just, we're just waiting on it arriving, but it's all got to be delivered in day. So there's nothing, as David said, we've balanced 2 or 3 numbers, but our good planning this year, where we said we wouldn't be right up to the wire, that got taken away. We're getting some extra government capital funding that we felt it was too good an opportunity to not take, especially for equipment. So, but we're confident it will meet the criteria again.
Thanks, Alan. Jerry, and then Susan.
Thank you, Boyd. And my thanks to Dave and the team. I think they presented very well. I think which is an extremely complex, complicated year-end position. I suppose my questions are my interest is probably more getting into 22-23 and whether the position for 22-23 is beginning to clarify itself. I think the letter which SG issued with this money, which they've issued very late in the day, this 40-odd million, which Dave has spoken about, highlights or sets out what the calls on that should be in relation to COVID and reinstatement of services and all of that. And I just wonder if we're beginning to get clarity now, David, on where we believe we're starting 22-23 and where we might be moving forward.
We're getting there. We certainly submitted a return to government last week with an initial kind of assessment of what we think the challenges we're facing in 22-23. And we expected, as we said in the board previously, and you said yourself, Jerry, we're expecting an initial gap in the 50 millions to start with as an underlying deficit, which will be mitigated by savings and by hopefully some flexible use of some of that resource that's coming into next year. The initial kind of assessment so far has still been that would probably result in a shortfall of about £16 million, and we're in discussions with government right now before we submit the kind of final template as to what that number will be. I think is it comfort or is it simply make you feel better? But other boards are of in the same position, and my understanding is that there's no balanced board in mainland Scotland right now looking at 22-23, which people would expect given the impact financially in the last couple of years. So we're amongst the crowd, I think, in terms of what our assessment of the financial position is next year. We're working it through, and hopefully we'll bring a paper to the next board meeting, given a bit of detail and a bit more meat on the bones.
Yeah, thanks. Susan.
Thank you, Chair, and thank you for these reports. Really good to be able to see this position. My question does relate to this report, but also relates to other reports that we've got in our pack, and it's a general point about the proposed levels of assurance. And it was my understanding when we discussed this last time that if we were given a moderate level of assurance, there would be with that a very short statement saying what it would take for us to get substantial assurance, given that we want to get substantial assurance. It might be one very specific thing that would be needed, or is it a more general comment? So just some helpful orientation around those assurance levels. What the executive believe would take us up to substantive would be really helpful. Thank you.
My apologies, Susan. I think reflecting as I did this morning when I was looking at the SPAR again is I think in the current year, given the resources from government, we should probably be showing a substantial level of assurance in this report, to be honest with you, because we have been funded up to delivery of break even and our targets. So I think in hindsight, we probably should have had that ticked as in that way. I'm sorry.
Don't know how others feel, but I would agree with that. We should be looking at a substantial level of assurance given the break-even position for this year. Okay, I see indications that people are content with that. I think we can move forward then with that. David, thank you very much for not just for the report, but for all the work you do to bring us to this stage, and also to your team, Elaine, and others in your team.
Thank you.
Can we move on to the budget offer for the IJB, Argyll and Bute?
Yes, thank you. I mean, this is relatively straightforward. The budget offer for Argyll and Bute IJB is normally the NRAC share appropriate to Argyll and Bute that's published. Last year, the IJB, we were grateful that they were flexible in terms of allocating a slightly less than NHS share last year, to allow us to submit a balanced budget at the time. But the commitment given last year when we set that was that we'd return the IGB back to its full NHS share in 22-23, and that's what this paper proposes. Highlights an NHS share of the baseline allocation and makes an assumption of other allocations which are adjusted as the year goes on. I've gone through these numbers in this report with the Chief Finance Officer, who is content with them, and it's put forward to the board for approval.
Okay, are there any questions? Any questions? I take it, Sarah, you're content with this offer?
We're very content, thank you.
Okay, thanks. Can we therefore take substantial assurance from the report and approve the offer? Okay, thanks. Thanks again, Dave.
Thank you.
And we move on now to the National Treatment Centre and invite Deborah Jones to speak to the assurance report.
Thanks very much, Chair. Hopefully everyone's had a chance to read the report and review the contents. I'm going to take members through sort of the report and just highlight a number of, I think, key issues. So the construction programme is going really very well. We commenced in the summer of 2027. We're approximately 87 weeks into the building programme, with about 27 weeks left of the construction programme due to remain. We did have a slight 6-week delay in the planned programme, which occurred as a consequence of some technical issues and supply chain issues and problems with the impact of COVID. However, in saying that, subject to no further delays, we're considering the completion date now to be the 20th of September, with an operational go-live date of the 13th of December. And having discussed this with clinical colleagues, we're confident that we'll be able to start phasing treatments from this date. Colleagues will be aware that the treatment centre is primarily going to be providing uncomplicated hip and knee surgery. It's going to be an entire eye care service, and we've also added foot and ankle and hand surgery into the range of services that we're delivering. We're in the process of recruiting, as you're aware. We have an additional 210 staff that we need to recruit, in addition to existing staff who will rotate and support the delivery of care once we've moved in. And I'll come on and speak a little bit more about recruitment in a minute. In terms of the construction programme, we have a great working relationship with Balfour Beatty, our preferred supply chain provider. We have somewhere in the region of 140 people working on site on a daily basis. We're pretty much at a point where the cladding is complete. It's around about 60–65% complete. We're in the process of putting in our theatres, and you know, I think Balfour Beatty need to be commended in terms of the health and safety record to date on site. There's been quite a lot of work been going on over the last few months in developing what we're calling the target operating model, which is basically the business function of the service. And as you'll be aware, we recruited our NTC manager in the latter part of last year proleptically to come in and support me as the project director. I won't go through the detail of the organisational structure, but it's clear in terms of once we hand the building over and it's operational, the NTC will be part of Catherine's acute services division. Helen will be reporting to the Deputy Chief Officer. And again, what you'll see within the organisational structure is we're in the process of recruiting a clinical director who will report to the Deputy Chief Officer, but will have a professional line of accountability to the Deputy Medical Director. The activity profile, I recognise it's bright, it's probably not the easiest read, but it kind of gives an idea of the complexity of work that we're having to address in developing what is a new service model. There can't be there's always going to be change and transformation when you are looking to introduce a new service. So this activity profile basically covers all of the dimensions and areas that we need to actually touch and change and consider as part of the development of the new service model. Excuse me. What I want to give some attention to is that we're planning to operate the NTC over a 5-day week. And our clinicians have, right from the get-go, been very keen that they deliver best-in-class performance. We're in the process of making additional appointments to anaesthetic consultants and other clinical staff. And what we're assuming is that all Band 5 nurses will rotate between Regmore and the NTC. This is on the basis that they'll be relatively newly qualified and need to get a broad church of experience to ensure that their development and their continuing professional development happens in a way that is well managed and they're not pigeonholed into one area. We spent quite a lot of time last year engaging with staff, and as a consequence of that staff engagement, we developed a people plan. Figure 3 sets out the sort of summary of what that people plan. It is consistent with where we as an organisation are going with our culture programme. And the ongoing engagement is being supported by colleagues across the entirety of the organisation. Recruitment, I think it's a really important element of the development. We commenced a phased approach to recruiting in 2020-21, and the paper sets out the scale of that recruitment through 2021-22 and this year. We're about to go into our major recruitment programme, particularly for our Band 5 nurses and other grades. And as a consequence of this, you'll be seeing quite a lot of activity, both from a social media perspective and the support that we're getting from Muckle Media. And again, I'll come on to that in a minute. I've included in the paper an indication that we're spearheading a national, international recruitment programme, and we're looking to recruit. Initially, it was 4 Zambian nurses. Unfortunately, one of our nurses who passed the interview has decided that she wants to stay at home rather than move across to Scotland. But so we have 3 active candidates that are going through the immigration process, and we're hoping that they'll be joining us early in the summer. The next section sets out the service model that we're developing and some of the activities that are included in the process that we're undertaking. We're also completing a series of service reviews for orthopedics and ophthalmology. This is to provide us with the baseline data that will allow us to negotiate the level of capacity we'll be able to have control of within the NTC, and what activity will be available to other boards across the north of Scotland and Scotland. The next section deals with public relations and communications, and as a board you'll be aware that we have put a huge amount of pressure on Ruth Fry's team with all of the activity and all of the developments that we're undertaking. So the project board made a decision with the support of executive colleagues to engage with a third-party organisation, and Muckle Media, having gone through a tender procedure, was awarded the contract to work with us. We've been working with them on our campaign for recruitment, Aim High, Aim Highland, and we're now in a position where we'll be using that strapline as a basis for all of the recruitment activities across the NTC, but also it is likely that this will be adopted as an NHS Highland approach as we broaden the scope of the recruitment campaign to include all recruitment that we're going to be taking forward for clinical posts over the coming months. In terms of financials, I've got a section that sets out the overall investment in capital, which is £43.6 million, and we're looking at a £13.5 million revenue consequence. The risks are set out in 3.4, and I'm happy to take questions. I recommend that the board members note and take assurance from this report, but happy to take questions.
Just before I invite questions, I should say that we hope to have a presentation from Deborah at a development session showing the layout of and design of the new facility. So you'll get another opportunity to question her then. But for now, questions for Debs. Alex.
Thanks, Mike. Yeah, thanks, Deborah. It's good to see this coming along at pace, which is great. In terms of your workforce, your 210 staff or additional staff, I'm assuming that a lot of that recruitment has been aimed outside. But is there a risk that you're going to get transfer internally from staff, and therefore, although you've got the vacancy covered, there's other vacancies elsewhere within the board area? And in that situation, what are we doing about it? How are we highlighting it, and how are we going to fix it?
Thanks very much for that question, Alex. And I think you're right to raise it as an issue and concern. We've had some interest internally, of course. One of the, I think the critical factors is the NTC cannot be in competition with the rest of the organisation. And it's really, really critical that as we move forward, we use the opportunity of the PR company that we've engaged to support the broader recruitment approach that we're wishing to take. So we've now, we're working with Heidi and Heidi's team. We're working solidly with Fiona and the recruitment team, and have a campaign plan going forward over the summer to maximise the scope of recruitment across all areas within NHS Highland. It will always be a risk, though, Alex, that there will be people that inevitably look at this new opportunity and see that as a career possibility. And I think we should be encouraging people to look at that. But at the same time, we have to look at recruitment holistically and across all of the corporate areas.
Thank you, Alex and Debs. Fiona.
Yeah, it was just to support what Debs has said there. It's absolutely about us working in partnership and collaborating to find the best opportunities for people, because the proposition of the treatment centre and some of our other areas of expansion like vaccination offer a slightly different alternative for some people at a different point in their career. So it's about how we kind of look across the whole kind of opportunities we've got available and try and slot people into them. And I think the approach Deb's mentioned as well around the fact of having, you know, the band 5 nurses cycling through the centre is quite important as well, because the centre will give people an opportunity to develop different skills and experience, but equally I've also been able to then translate that back into the sort of non-elective side of things will be really important. So I think we've definitely established really strong relationships there, and I think we're going to benefit from it as we move forward.
Thanks, Fiona. Heidi.
Thank you very much. I just wanted to come in really and just sort of say, Alex, not without its challenges for sure, but I have to say that we have worked extremely close together to minimise the risk. We've mitigated where we possibly can, but Debs is right. This is an opportunity for staff, and that's really important. We are rotating staff, and that will help us, I think. And as I say, we're recruiting ahead of the time as well, and that should ease the impacts. There won't be a sudden recruitment from existing staff. It will be spread over time. But I just wanted to say something very positive as well, which is the nurse directors in Scotland have been discussing the NTC, and what we're noticing is that we can recruit to the NTC. There may be challenges, and there will be different levels of challenge in different areas of the country, but this is a very popular thing that people want to be part of, and we do wonder actually whether there is some more universal learning from what we've achieved through working in the NTC, and Deborah has put her own brand on it, and it is an all singing and all dancing, and I think there is something for us to learn about that in terms of how we apply that learning in the future to our existing areas and staff, and try and make them more attractive and ensure that people want to work there. and transfer that learning. So that's something good that I think will definitely come of this.
Do you want to respond to that, Debs?
I think Heidi's absolutely right. I mean, we've worked extensively with our staff. The engagement piece that we took on board during 2021, 22 was critical in terms of illuminating what our staff are saying they want from us as an organisation and what they're willing to give. I think people are genuinely excited with the opportunity, but at the same time, we have a very grounded workforce here in Highland, and they're embracing the opportunity and the challenges that this new service will bring. But fundamentally, what everybody is saying, they want to use this as almost a test bed to create new ways of working, which are slightly more challenging within a mixed economy hospital. So I think we're in a very good place. It's not going to be easy, but I believe in our workforce in Highland, and I think that they are fantastic, and they are willing to go to the nth degree to deliver high quality care. And this is an opportunity that we should use it at every cost.
Anne.
Hi, Deborah. So this isn't my area of expertise by any means, but I wondered if you could say something about the sort of non-clinical benefits that we've been realising through the construction process. So perhaps, training of apprentices, or, I understand there's quite a lot of focus goes into that side of things. I wondered if you could say a little bit about how successful we've been with that. Thank you.
Thanks very much, Anne, and yes, and thank you for the question. Back, I think it must have been in 2021. I think it was you, Anne, that raised an opportunity to introduce the construction programme to a programme around education. And as a consequence, I had a discussion with Balfour Beatty quite early on, and they're familiar with the programme of linking with schools. So we're linking with an academy within Inverness, or at least Balfour Beatty are, so that we have a cohort of students that are working with the construction team on site and within the classroom, understanding what the opportunities are in the construction industry, and they've been doing exceptionally well. I think they've had 2 site visits, but I'd need to check whether that's accurate, because we had some issues with COVID. But that's just one of the schemes that are going on. Balfour Beatty have a programme of community engagement. It's part of their construction contract, as it were, that they will engage with the public, and they do quite a lot of fundraising. And we've been really proud and really sort of engaged with Balfour Beatty in terms of those endeavours. So they're just 2 examples, I think, of what's been going on.
Thanks, Debs. David.
Yeah, thank you, and thanks, Deb. I just wanted to emphasise the challenge of workforce is not only about recruitment, but also about retention and development. We heard earlier from our lab staff and recognised there the importance of training and development. And this opportunity for NHS Highland opens up that quite considerably from what we've had before. So it is important that we are able to not only attract new staff, but also develop and train the staff that we have. And, innovation we've talked about is a real challenge. How do we do things differently? I'd probably say this single piece of work, if I can call it a single piece of work for a moment, is probably the biggest challenge and equally opportunity about doing things differently. And starting from that blank page, if you like, it's been a real opportunity for the teams to develop those new ways of working. And that includes development of staff, that includes recruitment. And I think, we haven't gone about recruitment in the same way that we do recruitment everywhere else, we've also taken the challenge of innovation in this area too. And that's to be commended to Deb and her leadership, as well as the team and the way they've approached it.
Thanks, David. And of course, this is not the only project that Debs has been involved in. I'm sitting in Broadford Hospital today, Debs, and it's a magnificent new facility. We also have the new hospital in Aviemore, the Strath Bay one, and by the end of the year, we will have the NTC. And this is one of 10, is it, national treatment centres?
It is.
And
yes,
this will be the second to come on stream.
Yeah, it's probably second or third. I'm not quite sure where one of the other boards are at the moment. I'll be getting an update from the national programme perhaps later this week. But it's certainly one of the front runners, Boyd.
It's only 5 that has opened so far, and that's a much smaller facility. But it's a vitally important facility for the Highlands, and not just for the Highlands. It's a national treatment centre, so it will extend its range beyond the Highland board area in time. But it's of very great significance for the people of the Highlands and Islands and the services that will be provided there. So thank you, Debs, for bringing us information about how the project is proceeding in terms of build and in terms of a wider infrastructure, and also in terms of workforce recruitment as well. And I think having visited it recently, I was impressed by it, the scale of it as well, and that it will be delivered on time in September. The workforce seems to be quite sure that could be achieved. So that's encouraging. And we're being asked to take substantial assurance from the report that Deborah has presented us with. Are we happy to do so? Okay, thank you very much. And you took us to lunch on time as well. Thank you very much. That's an added bonus. And before we break for lunch, I just don't want to lose sight of the point that Susan made about moderate assurance. Ruth, if we capture that in terms of our board assurance framework going forward, that it's something we should reflect on and keep in mind.
Certainly will, yeah.
Okay, can we have a break till 1 o'clock then?